Fine. First of all, thank you very much for joining this lovely evening. Thank you very much, Abraham sir, for joining from Bahrain. Thank you very much, Senthil sir, for joining from Chennai. And all my dear friends, Shani, I could see Sunil has also joined. Vijay Bahadur sir, thank you very much for joining. So it's a high time that we must start a program. Ideally, we usually wait for 10 minutes, like we usually start a program by 7:10. But since Deepak sir has other commitments, so I take your permission so that we can formally start a program, so that we conclude our program on time with a fruitful discussion, and give ample time for Abraham sir to discuss, so that we can gain good knowledge from all our faculties. So before I formally start my program, first I would like to thank you once again for once again joining us in Brendos meeting. So a brief about Brendos meeting for those who have newly joined us. Brendos is the Breast and Endocrine Society. Initially, we started in Western UP. I hail from Western UP in Meerut, and so we started this program in Western UP. But now this has a pan India effect. Even we have faculties and participants from across the world, and anyone who has a special interest in breast and endocrine sciences, especially endocrine surgery, they take out their precious time to join us on every last Friday of the month at 7 p.m., where we discuss about breast problems on every even month and endocrine problem in every odd month. So now this November is an odd month. So this time we have a very interesting endocrine problem that we are going to discuss. So we have various formats through which we present our problems, and we try to discuss those. One is that we pick one very interesting case. We discuss about that case in detail with the actual images, and we bring out the questions why we have chosen that case to discuss. And with the help of expert, a brief literature review, we just try to understand. And our main motive is, importantly, is to escalate our clinical understanding, so that next time if the same patient comes to us, visits us, we are at a better position to manage such cases. So we know endocrine disorders, especially endocrine malignancies, they are rare tumors, especially medullary thyroid cancer. Because most of the time, as an endocrine surgeon, as an endocrine specialist, whenever we discuss, we mostly limit our talk towards differentiated thyroid cancers or follicular differentiated thyroid cancers. But because medullary thyroid cancers, they are rare tumors, we it rarely find a right forum where we actually discuss about it. So in today's program, we have taken an opportunity with the help of an interesting case to initiate the discussion about medullary thyroid cancer, and with the help of experts, we'll try to understand how we should approach such patients. So we have very eminent faculties with us, and so importantly, one of which is Dr. Deepak Abraham sir. Thank you once again, sir, for joining us from Bahrain. And Brendos is thankful to you for giving your precious time. So for those, as such, Deepak sir, those who are attached with endocrine surgery forums, they know him very well, but still, to introduce, Dr. Deepak Abraham sir is the Chief of Medical Staff presently, and he's a medical director of King Hamad American Mission Hospital, Bahrain. And he served 2 decades as a faculty in Department of Endocrine Surgery at CMC Vellore, Tamil Nadu, where he completed his tenure as head of Department of Endocrine Surgery and Associate Director of Human Resources in 2020. And I had a very good interaction with him, especially when I was posted in CMC Vellore, and I saw the amount of work that Deepak sir, MJ Paul sir, and their team were doing, especially their work in field of medullary thyroid cancer was really fascinating. And today we have got an opportunity to interact with sir and to get all our queries answered. So our other faculty is Dr. Senthil Kumar sir. Sir, Dr. Senthil Kumar sir is a senior faculty in Department of Endocrine Surgery at Madras Medical College, which is one of the oldest medical colleges of India. And he is a senior endocrine surgeon at Apollo Hospitals. And he both of them has incredible research papers and lot of accolades in their name. Thank you very much, sir, for joining. Our third faculty is Dr. Amit Upadhyay. Dr. Amit Upadhyay is a senior medical oncologist who has consented to join us. Through him, we would like to understand more about the chemotherapy or the medical management of medullary thyroid cancer. And sir is right now practicing in PSRI Hospital, New Delhi, and he is passed out from Gajra Raja Medical College, Gwalior. So a very learned person, and thank you very much, sir. He will be joining us shortly. And our other chief faculty is Dr. Anurag Srivastava, sir. He was supposed to moderate the program, but somehow he is right now engaged, but he will be joining us shortly. And we will be enlightened with his knowledge soon. Though sir deals with the breast surgeries mainly, but he is a director of Subharti Cancer Institute, Meerut. So he deals with other type of cancers, especially he has fascination for endocrine tumors because he is the pioneer of starting MCH in breast and endocrine surgery in All India Institute of Medical Sciences. So he is always a keen learner, and sir has consented to join us. He will be joining us shortly. So this was all about the basic introduction that I would like to give. So now may I request our guest faculties if we can start our presentation. I'm sharing my screen. So I hope it is now visible to everyone.
Yeah.
Oh, thank you.
Yes, we can see it. We can see.
So all that I have told about Brandos. So we start with the case of a 45-year-old female who presented with an innocuous solitary thyroid nodule in her right lobe of thyroid, which was there for 2 years and it was gradually progressive. She was not much bothered except for past few days. She noticed and she thought of consulting. So when she presented to us, there was no significant personal or family history. Everything was non-contributed. Imaging was also reported something like colloid nodule. That was a thyroid 3 lesion in her right lobe of thyroid. But her story suddenly changed when we asked the patient to get an FNAC done. Her thyroid profiles were normal. And I request my co-speaker, Dr. Chani, to explain about the reports that the FNAC report that she received.
Thank you, ma'am. So on fine needle aspiration, we found there were loose groups and singly lying cells. Cells were spindled to ovoid in shape. If we look at the photomicrographs, at higher magnification, 400x, we can see ovoid and spindled cells. And the cells had granular or stippled chromatin. It might not be appreciable in the photopicrographs, but stippled means finely granular salt and pepper appearance, which we usually find in neuroendocrine origin cells. And few plasmacytoid cells were also there. So there was a suspicion for medullary carcinoma thyroid, and serum calcitonin levels were suggested for further evaluation. If we see a classical, in general, in medullary carcinoma, we find cellular smears, and it is a tumor with a varied morphology. So we can find round, ovoid, or plasmacytoid or spindled cells, singly or in clusters. If we see the photomicrographs here, in the left side, we are seeing a tumor with predominantly plasmacytoid cells, plasma cell-like cells, and on the right side, we can see spindle cells, which are much like our own case. And there is abundant cytoplasm, and chromatin has a stippled appearance as in our case, and pink ageroflake granules can also be seen.
So now that story's changed. That was not a colloid-like nodule. That was a medullary thyroid cancer. So our next step, we did a serum calcitonin, which was more than 20, but less than 100, 87.5. We did a serum calcium analysis and metanephrines we suggested, but the patient had a financial constraint, so they did not get it done. So we just measured the blood pressure, and we just measured the blood pressure. She was normotensive, and somehow we took her up for surgery. So why we measured this metanephrine and calcium, that we will take on later. So we did a thorough neck ultrasound, and we did not find any suspicious finding except for that thyroid nodule. And we took that patient for surgery. We did total thyroidectomy with bilateral central compartment lymph nodes. In addition, we found some lymph nodes in the right and the left, ipsilateral and contralateral lateral compartment lymph nodes, lateral compartment, and we sent them for frozen section biopsy. Though those were reported as negative, but looking at the financial condition of the patient, we did not take any, our surgical team did not take any chance, and we did a prophylactic level 2, 3, and 4 lymphadenectomy in her case in August. Sorry, that was not 2028, that was 2024. And the specimen was sent for histopathology examination. And I request Dr. Chani again to explain the images to us.
Thank you, ma'am. So in general, in medullary carcinoma thyroid, on gross examination, tumors are unilateral and sporadic cases and bilateral or to multicentric and hereditary cases. And since they are derived from parafollicular C cells, so the localization is usually junction of upper 1/3 and middle 1/3 of thyroid lobe, which has a higher density of parafollicular C cells. Size can vary from less than 1 to large tumors replacing entire thyroid. They are usually well circumscribed but unencapsulated, and cut surface is solid tan yellow. If the size is less than 10 mm, we call them medullary microcarcinoma. So in the images, we can see a classical cases of medullary thyroid cancers with a yellowish tan cut surface. So in this case, this tumor was unilateral and unifocal. It was at the junction of upper third and middle third. Size was 1.8 into 1.2 centimeters. It was well circumscribed and cut surface was solid tan, pale yellowish. And there was a central hemorrhagic spot. So on microscopy, this is a tumor of varied morphology. So many patterns can be seen, like solid, nested, trabecular or insular growth pattern. There is fibrovascular stroma, which gives it an organoid appearance. Cells can vary from plasmacytoid to polygonal to spindle. Atypia is usually low to moderate. Necrosis is uncommon, and amyloid deposition is seen in 50 to 60% cases. In our case, the tumor was well circumscribed, but it was also encapsulated. And the histomorphology showed the nested pattern along with follicles, solid areas, and broad trabeculae with fibrovascular stroma. There were thin septae. Cells were spindled as well as plasmacytoid. Atypia was low, necrosis was absent, and amyloid could not be identified. Next slide, ma'am. So on final impression, medullary carcinoma thyroid of right lobe was made, and the staging was T1B, and lymph nodes were found to be negative, and immunohistochemistry was suggested for further confirmation.
Okay, so post-operatively, we asked the patient for serum calcitonin, and which was less than 2. So it confirmed that there was some source of calcitonemia, which we have taken care of, and now the calcitonin is within normal range. So why we chose this case for discussion? We chose this case for discussion so that we can refresh the basic understanding of medullary thyroid cancer, and to understand how we should work up and manage, what are the management protocols exactly. We would like to understand through this presentation what is the role of calcitonin, what are the exact values we must take care of, and CEA, what is the role of CEA, and also if such patient presents with suppose recurrent or maybe advanced medullary thyroid cancer where we are not able to perform surgeries, how should we manage such cases. So a very brief about medullary thyroid cancer, though all those who have joined us are either general surgeons or endocrine surgeons, but still to refresh, it is one of the rare thyroid cancers. After differentiated thyroid cancer, it is the third most common thyroid cancer. It is around in 1 to 5% of cases we see such cancers, and it is derived from the parafollicular C cells, which are neuroectodermally derived. They specifically secrete calcitonin, which is its essential feature. It helps in calcium regulation, and they are most concentrated in the superior pole. Therefore, tumors are also found most commonly in the superior pole. majority of the clinicians, they often confuse between differentiated thyroid cancer and medullary thyroid cancer. For them, this one slide will help them differentiate both of them. Importantly, medullary thyroid cancers are very, very less compared to differentiated thyroid cancer. They derive from parafollicular C cells and not from the follicular cells, right? They are in 25% of cases, they are hereditary. So suppose if you see 100 cases, 25 cases are maybe, there are chances one-fourth of them may be hereditary. The tumor marker there is follicular thyroid cancer, there are no significant hereditary association. Tumor marker we use here is calcitonin and not thyroglobulin, which is used in differentiated thyroid cancer. There is no definitive role of adjuvant therapy, only in palliative care we use it. Therefore, there is no role of any radioactive iodine ablation or TSS suppression that is there in differentiated thyroid cancer. Also, it is one such tumor where we recommend doing prophylactic thyroidectomy in subset of patients, and also it has a poor prognosis compared to differentiated thyroid cancer. At the time of presentation, majority present with lymph node metastasis, approximately 50%, and 10% may present with distant metastasis. Why? Because these are aggressive tumors. These are very aggressive tumors with tendency for lymph nodal metastasis and distant metastasis. So in sporadic cases, which are around 2/3 of cases, still if we assess the tumor marker, we may find RET mutation in 50% and RAS mutation in 15%. Why this is important, that we will discuss later on. And usually these patients present in 4th to 6th decade, like in our patient, which was in her 4th decade. Hereditary tumors present bit early. There are 3 important type of hereditary tumors: familial medullary thyroid cancer, MEN2A and MEN2B. MEN means multiple endocrine neoplasia. In today's program, we will not go into detail of the endocrine neoplasia syndrome. Just a brief overview that in MEN2A and B, medullary thyroid cancer is always present with pheochromocytoma, but in MEN2A, there is parathyroid involvement, and MEN2B, there is no parathyroid involvement as such, but some marfanoid habitus, with the help of some marfanoid habitus, you can identify and mucosal neuromas, you can identify that this patient could be an MEN2B. And it is very important because MEN2B is a very aggressive disorder, and we have to manage them very aggressively. Also, once the tumor is detected, then we have to classify the patient, stage the patient in the form of TNM staging. This is the TNM staging regarding tumor, node, and metastasis. It is the conventional, like less than 2 to 4 and more than 4 centimeter that we usually see in other cancers also. So why it happens is because of red proto-oncogene mutation. So now understand why such tumor arise. There is a red proto-oncogene mutation. Red proto-oncogene encodes a tyrosine kinase receptor, which is a growth receptor. So whenever there is a mutation, there is abnormal growth, differentiation, and development of nerve cells, which leads to cancer formation. So these cells become overactive and cause abnormal proliferation. And these patients, they usually present with, like any other thyroid nodular patients, like a thyroid nodule, but if it gets neglected, then it may progress and may present with lymph nodal enlargement. They may cause local symptoms like dysphagia, hoarseness, or dyspnea, and they may present with some paraneoplastic syndrome. So this is interesting. The patient may have features like Cushing or carcinoid syndrome. Patient may have diarrhea, unexplained weight loss, flushing, erythema, itching over the body, and if the lesion is has metastasized, then any symptom related to that particular organ may arise. So this paraneoplastic syndrome is very important. Now, how we should work up these patients? So there are 2 clinical scenarios. First, patient presented to you and you diagnosed preoperatively that the patient may be having medullary thyroid cancer through FNA, or there is another scenario where the patient was overlooked and the patient was operated, either hemithyroidectomy and total thyroidectomy, and then on final histopathology, we diagnose the patient as medullary thyroid cancer. So a common scenario where we preoperatively diagnose a patient, what we have to do, we have to first assess the basal serum calcitonin level preoperatively and carcinoembryonic antigen. Both are secreted by the C cells. Also, we must screen the patient for pheochromocytoma. We must screen the patient for parathyroid tumors, hyperparathyroidism in the form of serum calcium. Also, if possible, it is always advised that we also do a germline red proto-oncogene mutation analysis so that we know the extent of surgery that we have to do and also the pre-operative preparation that we must do, and also to whether we should screen for the family or not. Thyroid and neck ultrasound to assess your extent of surgery and vocal cord mobility that we know. Now important, if the calcitonin is more than 400, it is recommended to screen for distant metastasis, in which we screen for lung, liver, bones, and brain if symptomatic. Here it is important, like in breast cancer, we do it with PET scan, FDG PET scan, but FDG PET scan or DOPA PET is not recommended in cases of medullary thyroid cancer. So please understand, don't ask a patient to get PET scan if they are diagnosed with MCT, because they are less sensitive, especially when calcitonin level are low, less than 1000. So what we ask for, if required, you can ask for gallium DOTA scan, which is relatively has a better sensitivity. And suppose if the patient is diagnosed after surgery, so we cannot have a pre-operative serum calcitonin level. What the minimum we can have, we can just measure the basal serum calcitonin level. Later on, we can follow up that calcitonin level, and also screen for red proto-oncogene mutation, and to see whether we have left any cervical lymph node. You can just screen it again and to see whether lateral or central lymph nodes are involved or not. A bit about hypercalcitonemia. Calcitonin has a diagnostic, prognostic, and predictive value. How? Ideally, it should be less than 5 or maybe 8.5 in some studies they have mentioned. And if it is more than that, suppose 10 to 100, the chances of medullary thyroid cancer is between 25%, 25 to 30%. So not all patients is medullary thyroid cancer if it is more than 10. More than 100, definitely it is a medullary thyroid cancer. But below 100, it could be because of other conditions also, like thyroiditis or in colloid nodules also, sometimes we get high calcitonin level, but not more than 100. So suppose any patients with a thyroid nodule, 10 to 100, chances of medullary thyroid cancer is always high, but not 100%. Now, calcitonin is a very specific marker because it is exclusively secreted from the parafollicular C cells. But only one point interpretation is not useful. Rather, we have to measure the trend. So for right evaluation, and it is always advisable to collect it while fasting, avoid heavy meals or alcohol a night before, and also it must be performed before any imaging technique, especially when iodine contrast if we are using. And also, please ask the patient to get the calcitonin level done from the same lab, because reagents, the reagents with which we are evaluating also matters. CEA level, it is less specific because it is secreted by other cells also, like lung, ovaries, and in smokers, colon cancers, prostate conditions, also it gets elevated. It is less specific, but also it is very important to measure with calcitonin. That also we will discuss after a couple of slides. So suppose a patient presents with, now we suspect medullary thyroid cancer. So if I give a chart, you suspect medullary thyroid cancer, next thing you have to do? Please rule out pheochromocytoma, because if you don't rule out pheochromo or don't manage pheochromocytoma and you directly go for cancer surgery, thyroid cancer surgery, you may go into catastrophe, because patient may have an exuberant hypertension which may damage the organs. So it is always good to control this pheochromocytoma first, operate the pheochromocytoma, then go for thyroid cancer surgery. So surgery is the only curative modality. But what surgery we must do depends upon various factors. So suppose surgery is the only curative modality. Any other therapies, if we talk about chemotherapies, if we talk about radiation therapy, they have a palliative role. So because it is the only curative modality, we cannot take a chance leaving behind any tumor, because then there is no adjuvant therapy, significant adjuvant therapy which we can offer. So if the tumor is less than 1, very low burden disease, no suspicious lymph node, calcitonin is also low, the minimum surgery that is advised is total thyroidectomy with bilateral central neck dissection, whether or not the central nodes are positive or not. Prophylactic dissection is very well established in medullary thyroid cancer. There is no debate about it. But about the lateral lymph node dissection, it is recommended, suppose if the tumor size is more than 1, or there are suspicious lateral lymph nodes on ultrasound, or positive central lymph node. It is always, and the calcitonin is also high, it is always advised to go one step ahead and do a prophylactic ipsilateral lateral compartment lymph node dissection. Okay, and if the ipsilateral lateral compartment lymph node is positive, or there is a bilateral disease more than 1 centimeter, or there is an extensive lymph node involvement, contralateral nodes, suspicious nodes on ultrasound, then very well we can go ahead with contralateral lateral neck dissection. So surgery is the only curative, and we must do it extensively in the first go itself. That is curative. Okay. After surgery, what to do? After surgery, there are 3 important things that we must take care of. First of all, monitor the patient with the help of tumor markers like calcitonin or CEA. Beyond a certain point, if you suspect there is some sort of recurrence, identify it with the help of imaging, and not to forget to replace the thyroid hormone, because there is no thyroid. But importantly here, we do not need a suppressive dose of thyroxine. We just need a replacement dose of thyroxine. Not like differentiated thyroid cancer, we don't need suppressive thyroid. So what is recommended after surgery, you again measure a basal calcitonin post surgery and compare it with the preoperative level. Now this post-operative basal calcitonin is your baseline, and you monitor 3 to 6 monthly the serum calcitonin level to see the trend, whether it is rising, stable, or declining. Okay, so this is called calcitonin doubling time. If it is less than 6 months, in less than 6 months, if the calcitonin level doubles, suppose 10 becomes 20 or 30, then it is not good. The patient must be then religiously followed up, more closely followed up, and to identify the source with the help of imaging. And if it is more than 150, then definitely we must rule out other organ involvement like liver, lung, through with the help of imagings, right? And I talked about the role, the relationship between calcitonin and CEA. So, like suppose calcitonin, just see the 4th graph. Calcitonin is declining, but CEA, if it is increasing, okay, then we must have a red alert. Maybe there is some dedifferentiation sort of thing, and either there is dedifferentiation of medullary thyroid cancer, or there must be some other source of CEA production, and we must rule out ovaries, we must rule out prostate, lung, and other areas. Okay, so this is a predictor of poor survival. So calcitonin doubling time is calculated every 3 to 6 months for CEA and calcitonin. 4 data points over minimum of 2 years is required, and significant survival difference is found in patients with doubling time more than 6 months, which have a good survival, and less than 6 months, which have a poor survival. So you can use this type of table in your patient's case file or OPD file, where you can note down the date, the calcitonin level, CA level, and you can compare it. Okay. Now about adjuvant therapy. So there are 2 adjuvant therapies. We call it tyrosine kinase inhibitors. I don't think there is some intravenous therapies that we are using now. Maybe our experts can help us regarding this. And radiotherapy. But please understand, when to start the systemic therapy, this decision to start systemic therapy should not be taken lightly. Because these drugs are very toxic. They are not curative. They require closer follow-up. They require most of the time a long duration therapy, and there are chances of drug resistance. Okay. So there are two type of tyrosine kinase inhibitors. So those tyrosine kinase growth receptors we have already talked about. What we do in such cases, we block those receptors. So there are two type of inhibitors. One is multi-kinase inhibitors, and second is selective RET inhibitors. So you can understand in multi-kinase inhibitors, they have a non-specific action. So many other non-RET kinase inhibitors are also inhibited, which produces side effects. So there are two important drugs. They are approved for being used in medullary thyroid cancer: vandetanib and cabozantinib. And then there are selective RET inhibitors, and you can understand they're specifically for RET tyrosine kinase receptors. So they produce less side effects to the patients, but then definitely they are costly, and they are sell per catinib and pralsetinib. Pralsetinib, right? Okay. It is not like we can interchangeably give any patient vandatinib or cabozantinib. They have specific indications and contraindications. So I'm not going into detail of this. The important is that there are two important drugs, and these drugs are very toxic because there are studies that have found, like suppose with vandatinib, there is 12% dropout because of toxicity, and 30%, 35% required dose reduction. Similarly, carbozantinib, they had 16% dropout and 79% required dose reduction, which is a significant number. So these drugs are not very well tolerated. Okay, now coming to radiation therapy. So in whom we should consider radiation therapy? These are considered in patients with gross residual unresectable disease. Basically, any patient where we are not able to do the surgery, we have to control the disease with the help of chemotherapy or radiation therapy. So another important point about chemotherapy, they don't cure the patient, they only control the disease. So easily, for any patient who already has a very low burden of disease, it is not recommended to start chemotherapy in those patients. It is always advised to follow up those patients, because anyhow these medicines also, they don't cure the patient of that residual disease, you know? And the side effect is profound. Radiation therapy, whenever there is a gross residual unresectable disease, extrathyroidal extension, extensive lymph node metastasis, there is R2 resection, recurrent disease not amenable for surgery, or palliation of recurrent or metastatic disease. So if I summarize all these things, any disease which is unresectable, so where we have to consider radiation therapy. There are other therapies also: immunotherapy, tumor vaccines, PRRT therapies, and CAR immunotherapies. I'm not sure how readily they are available for patient treatment. And the survival, as in any other cancer, in initial stages we have 100% 10-year survival, but as the stage progresses, the survival reduces to 21% at 10 years. But I think still 10 years is a better compared to if we compare with breast, but it is poor if we compare with differentiated thyroid cancer. So follow-up and management of screen-detected germline positive cases. One of the last few slides, a bit about, suppose a patient presents with medullary thyroid cancer, we do RET mutation analysis, the patient come out to be positive. Then what next? Then that patient we manage for medullary thyroid cancer. But what next? The next will apply for the siblings, the children, and the other family members. So suppose they are also positive, what we should do? So it is recommended, if it is MEN2B, we do total thyroidectomy within first few months or within first year of life. So you can see like the extent of surgery that we are offering. MEN2A, we consider thyroidectomy before the initiation of medullary thyroid cancer, before 5 years. And MEN2A, which is a moderate risk, we can wait for some time. If we see the calcitonin levels are elevating, or if the patient prefers surgery rather than follow up, then we do the prophylactic thyroidectomy, and we screen pheochromocytoma in all such cases. And if it is there, we operate pheo first. So now if we conclude, medullary thyroid cancer is rare, but it is an important thyroid malignancy. Management is absolutely different from differentiated thyroid cancer. It is very important to rule out other endocrine neoplasia before any intervention. Genetic and family screening is very important. We must not take it into back foot. Follow-up is done with serum calcitonin and CEA. Surgery is the only curative answer, and first cure is the best cure. Adjuvant therapies are only for palliative intent in selective cases, and prognosis is relatively poor than differentiated thyroid cancer. Okay, so now with this, I conclude this presentation, and the case is now open for discussion. So I'm stopping my share. Okay, so there are many important questions, and sir, through these type of forums, because there is a mixed population, mixed participation of the doctors who are in private practice, and there are doctors who are giving their services in high volume government centers or high volume tertiary care centers. So there could be some conflict or related to the patient management, their follow-ups and other things. And in this forum, we are always open to discussion. What better we can do with such patient? So in this patient, first of all, metanephrines were not done. So what do you think? Because most these patients are poor patients with no government support. So may I request Deepak sir to please throw a light in any patient with apparently sporadic, but the genetic analysis is not done. What do you suggest? It is really very important that we must go for metanephrine, which cost around 7 to 8,000 at least from lab pathology or some other lab, or we can just follow up with these patients with BP monitoring and other thing. Just prepare the patient and just go in for surgery. Relieve the patient, cure the patient of medullary thyroid cancer, and if possible, maybe in future we can go in for genetic analysis. It is really mandatory.
Yeah. Okay. Thank you, Sudhi. I mean, it's a pleasure to be here and connect in a forum like this, discussing a favorite topic of mine. I will start by saying that you need to be we need to be careful, especially when we deal with patients with medullary thyroid cancer. Now, of which metanephrine analysis is something which is important, because otherwise you can burn your fingers badly, as you mentioned. So it is important that you screen the patient for a pheochromocytoma, and the best screen is actually a blood screen or a plasma metanephrine or a 24-hour urinary metanephrine. There are, I don't know if those tests are even available now, but there are tests which are available which you could use to measure, I mean, at least to give you a guide. The other route to do this would be to do an ultrasound abdomen or a CT abdomen if the CT was done as part of screening, as part of staging of the disease, and then you do a thorax and abdomen scan, and that would pick up an adrenal tumor if present, if you have not done a metanephrine. So these, and blood pressure, obviously. So you've got hypertension in a 55-year-old lady, and you're operating, and this patient's been on, let's say, 3 drugs or 4 drugs. Your risk of having, pheochromocytoma is quite high. So it would, I would say, yes, I would say, in an ideal situation, if you can get that metanephrine done, either plasma or urine, and then operate, right? Before you go into the neck. Because I have seen patients who have actually had disasters on table when operated without a screen. Okay. The second thing you asked me was about RET, and I would say that RET mutation. All patients with a medullary thyroid cancer should undergo a RET analysis if it is not even prior to surgery, but at least as a follow-up, because then you know what to do in the follow-up of this patient. And I will leave that to you because I've got some questions with regard to the case you presented, but I'll stop now and then ask you to respond. And then if you want me to speak again, I will.
Sure, sir. And so what about CEA? In your do you routinely perform CEA with calcitonin?
We did both metanephrines. We did calcitonin and CEA at start. You have a baseline. One value alone is not important. It is the serial values which give you a trend. And that is more valuable than single isolated values. So at baseline, we did both a CEA and a calcitonin. If your CEA was high at start, or relatively high at start, then you know that you possibly are dealing with a tumor which is high grade and later can dedifferentiate. But if you've got a very high calcitonin and a very low CEA, you possibly have got a tumor which is more well differentiated and will not go through this dedifferentiation later.
Okay, so we have received one question from Dr. Mithun Ram. His question is lymphadenopathy in MTC tender? Why is it so?
Okay, not all lymph nodes in MTC are tender, but often it is a rapid increase in size which causes tenderness. And it is the periadenitis which happens, and even if a tumor infiltration into the periadenitis capsule, extracapsular disease which can cause tenderness. So it is the rapid increase which causes the pain rather than actually the disease process having a pathology which causes pain. So it's the stretch of the capsule which can cause pain. But by the way, not all lymph nodes are tender.
Okay, and so now we have our another guest, chief guest, Dr. Amit Upadhyay sir has also joined. Thank you very much, sir, for joining us. And so there are a couple of questions related to, and Senthil sir, I'll come to you as well. So please keep yourself ready for this. And regarding chemotherapies, so what is your, suppose a patient you have operated and that patient has an extensive disease, though you may feel that it is a R0 resection, do you still prefer to give adjuvant radiation therapy to avoid recurrences, or and also to give adjuvant chemotherapies to avoid recurrences, maybe a course of maybe 6 months? I'm not sure about you. You are the right person, better person to tell me about this. Or you just leave that patient for regular follow-up. If you feel there is rising trend of calcitonin, then you initiate any adjuvant therapy in such cases.
Okay, first of all, thank you so much for inviting me, though I was a bit busy and I joined later also, so I missed your case. Anyway, coming to these things, as you have mentioned also, that chemotherapy has a very sort of limited role. Rather, traditional chemotherapy, which was being used at one point of time, that was dacarbazine based, practically nobody uses them unless there is some desperate situation. You mentioned about the small TKIs which are available. Vandatinib is not available in India as of now. We can get it on compassionate basis, but cabozantinib is there, and we have used them. But as you also mentioned, that the significant toxicity is there, definitely there, and there are very few patients, hardly any, who can actually continue with the recommended doses. We often have to sort of cut down the dose. Having said that, coming to the next part, that if we think that adjuvant setting you have operated, and should we use them only on the basis of that, whether we are not sure whether we got an R0 done or not, there may be some residual disease, I would still say go with the calcitonin level. If there is rising trend, use that.
Okay, so what about Deepak sir? So what is your, because like CMC, MMC, they are high volume centers. What protocol do you follow, sir, in high burden disease, sir?
So when we actually did disease burden assessment, and if you were going in for an R2 resection or an R1 resection, or you got mediastinal disease which is inoperable, or very extensive, we actually gave new adjuvant TKIs, and we actually gave a pre-surgery 3 months to 6 months of TKIs. And when we started this in 2014, and I remember my first patient who went on to that, we started with sorafenib. That was the only drug available. And we gave him 3 months of disease, or sorry, 3 months of TKI, and his mediastinal disease shrunk, but it didn't disappear. So what we did is we actually operated on him at the end of 3 months, but you have to give a 2-week window because these TKIs act on the blood vessel walls. They can thin it, so you can have excess bleeding. So you wait for 2 weeks for the drug's effect to be weaning off, and then you operate. And we did a total thyroidectomy, bilateral central neck dissection, and a mediastinal lymph node dissection, which took for about 14 hours of operating. And once we cleared the disease, we put him back on sorafenib. And we continued that. And his calcitonin, which was 30,000 plus, at post-surgery was 4,000. And with continuing him on sorafenib, he actually dropped down to, I think the lowest he went down was to about 2,000. And then it started climbing. And then by the time we actually started searching, he was a very educated guy. And he partnered. I mean, he actually did most of the work. He went on clinicaltrials.gov, found all the worldwide trials on MTC, and he gave me the contacts of all the primary investigators, principal investigators of all these trials, and I got him onto a trial for selpercatinib, which was called the LOXO 292, and with that, his right. So he got onto that trial. He had to fly to Singapore to get onto the trial because the PI who I knew was Australian, and he connected me to the one in Singapore, and that was a closest city for him. And so he flew to Singapore, got enrolled in the trial. He was hereditary MTC. He was 634 positive, and he is right now still on selpercatinib with a calcitonin of 117. And that's how good the disease was. He was stage 4 when he started. But the value of TKI is huge. And chemotherapy has pretty much no role. It is targeted therapies which can work. And even when you have drug escape, you can change your TKI from a non-selective to a selective, or from a selective to a non-selective, and then you get better results with these patients. And so I'll go back to one point. MTC is not a disease which, I must say, should be handled by anybody or everybody. It is, especially when you reach this stage, it's best to send it to a place which can handle the disease well. Initial surgery too also is very important because this is a surgical disease, and primary surgery is most important as opposed to trying to clear the disease after. So, you mentioned that the disease happens in the upper pole. It's actually in the junction of the upper and the lower 1/3, 2/3 junction, and it is posteriorly placed. And so it's actually at the point of the Berry's ligament. So when you operate, if you don't do a truly total thyroidectomy, you can have disease recurrence over time. And so that's why it's very important that the surgical clearance is at the first instance is the best chance of getting cure for this patient. And looking at your patient, I think you've got cure for this disease because you've done a calcitonin which has come to less than 2. And so you see that maybe I can challenge the need for doing a lateral lymph node dissection, which may not have been required because I did not hear a tumor size or missed it because the tumor size and the fact that there are no lymph nodes on a lateral neck on an ultrasound warrants a total thyroidectomy plus a bilateral central neck, and that should be enough. But going on to further treatments, which will come later, I would say beware of the fact that don't deal with these patients without having them gone to a place which can get them onto a trial. And I know right now, even in India, right now, patients, you must get them onto a clinical trial. And that today I know that there was a trial which was running out of Pune. And we had patients from Vellore who were not eligible for to get onto any kind of a trial with us, but we actually put them onto a trial in Pune, and they are getting onto the trials which help them, get better results. Yeah, I'll close with that. You need to unmute, Sudhi. You need to unmute.
Sorry. Yeah, I'm extremely sorry. There was some network issue from my end. My network is relatively slow, unfortunately. And I was listening to Deepak sir's experience, and it's really fascinating. Like, I think it is more than 10 years. 2014, you operated that patient, and 2010. So things are not that gloomy. And I think TKI is one of the factor why that patient survived. And so, like, TKI, though it is projected, it is very toxic, but it has a promising result. And this is one of the purpose that Brendos has served, that now we are more confident in giving TKIs to such patient. If suppose any patient come to us, sir, what are the specific complications that you might have encountered with such patient? What specifically we must look into while we are prescribing tyrosine kinase inhibitors? Sorafenib, you said, sir. What is the cost of sorafenib, like, in India to the Indian patients?
It's cheaper now, but it was around 26,000 for a month's therapy when I started. This is much earlier, but it has come down. But that's a non-specific RET inhibitor, so the better way. Actually, you must get the medical oncologist is the one who could guide you through that, and where could they get the sources. Very often patients can be connected directly to the rep, and then they have deals which help them get, okay, you buy so much, we give you this much free. And so that's how it works. And these patients today, selpercatinib is available in India, but it's prohibitively expensive. But the company was actually supporting through on compassionate grounds. The patients who I got onto the trials got the medicine free. So it's important to look for trials. And I know when I left India, there was a trial which I tried to get into Vellore, but actually they got a site in Pune. And I don't know how that happened, and I know one patient who was in touch with me after I came here. I got him on enrolled into a trial in Pune, and he went there, and it was basically at least an option, a window opened when everything was closed. So I think, remember, MTC is most often get cured, but when you have disease like this, it is best not to handle and keep them here. It's best to take them to a place which can tackle that well. Maybe for you guys, I don't know if it's in Delhi, but I know Tata Mumbai would be a good place to send for these kind of, to get them onto what are the best possible therapies.
Okay, so Senthil sir is also with us. So may I request Senthil sir, can you please share your experience? You have gone through the case.
Am I audible, madam?
Yes, sir. You are very well audible, sir.
Okay. It's a very nice case, and you have done a very good primary surgery, because the primary surgery is the most important one in the medullary thyroid cancer. Because you see, we have in our experience operated more than thrice. So it will recur again and again. See, I have the privilege of operating one in a big corporate hospital like Apollo. The other one is a big tertiary care center, government hospital, which is Madras Medical College. In Madras Medical College, we did not have a chemotherapy or a medical oncology regimen about 20 years back, but now sorafenib is freely available, and you in Meerut should now engage into a MTC group. When you have your previous patients and your new patients, your index patients, then the drug companies will give you medicines for your registry free. See, this is one way of tackling the situation. Then now coming to my experience part. See, first is the screening. See, any solid tumor, any one who has completed their family, if they are a lady beyond their middle age, then if there is a solid tumor, you should always suspect or rule out a MTC. You should do a calcitonin staining. Then sometimes there is false positive calcitonin. Sometimes the calcitonin will not show. Then we should do even a pentagastrin stimulated calcitonin. Okay, so this is just to mention. Okay, though many people are not doing pentagastrin now, in less resourceful centers, where the centers lack money, it is still handy. Okay. Same way, if you want to screen for a MEN, because you want to now know whether your medullary thyroid carcinoma is a MEN, a syndromic one. When that is the case, you have to do a contrast enhanced CT. Okay, contrast enhanced CT or a CT washout if it is a small lesion will give you a clue that you are dealing with adrenal neoplasm. Okay, then you can go for a higher urinary metanephrine or a normetanephrine workup, or else you can just subject to a VMA. A VMA is not very costly. Okay, so that again will rule out. See, this is not for confirming your diagnosis. This will rule out. Okay, so then comes the FNAC. FNAC itself will show a medullary thyroid carcinoma in the hands of an experienced cytopathologist. There will be nuclear grooving, nuclear fissuring, then amyloid stroma, abundant cytoplasm. Okay, so these are telltale evidence that you are dealing with a medullary thyroid carcinoma. As in your case, we have to subject to a primary radical surgery, because you see, whatever chemotherapy you give is only a palliative. Okay, that is more to satisfy your own or the patient's, like repeated follow up. Then comes your calcitonin and CEA. That is more for the follow up. As rightly pointed out, it is the serial estimation which will help. Then comes whether it is the medullary thyroid carcinoma, whether it is familial or sporadic. See, if the patient is lucky, they are sporadic, they fall into the sporadic group. Then you have to see whether they are syndromic. Syndromic, I have already mentioned how to go about. Now, coming to familial, see, familial will be autosomal dominant, aggressive, and it will be fast growing. And these are the ones which will cause pain and lymph nodes. So once it is familial, after surgery, you have to resort to the family screening and put the entire family in your MTC registry. Because you see, there can be a allele penetration and someone in the next generation will be able to obtain the disease. And before, it was advocated to undertake a prophylactic thyroidectomy in less than 5 years before it manifests, but now that has become a debatable point. So the prophylactic thyroidectomy itself has got two schools of thought. So it is imperative that even after surgery, we have to keep the patient on follow-up. Sorafenib will help. Immunotherapy will be very handy. When it is the corporate hospital, then TKIs, immunotherapy, and palliation chemotherapy to alleviate the symptoms will help. So this is the current situation and my own experience. Thank you.
Thank you very much, sir. So, Senthil sir has covered it exhaustively about, especially the familial medullary thyroid cancer. Thank you very much, sir. So we have another question from one of our audience regarding. Deepak sir would like to take if and Senthil sir also. What is your protocol? Do you send calcitonin once FNA is positive for medullary or suspicious for medullary thyroid cancer, or in any patient with a solitary thyroid nodule or nodular thyroid goiter, you routinely send calcitonin? So what is your protocol, sir?
Okay, maybe.
Yes, sir, Deepak sir.
Yeah. I think what a good guide to go through when to decide to do serum calcitonin pre-op is one, when you have routinely indeterminate FNA. Okay, that means you have a clinically suspicious nodule. It's a hard nodule. It is suspicious for malignancy, and the FNA is coming back. You've done it once, you've done it twice, and it's come back as indeterminate FNA. When it is a category 3, category 4 FNA, then it is a good guide to actually do a calcitonin pre-op. Okay, routinely doing a pre-op calcitonin may not make sense, especially if you've got Bethesda 2, Bethesda 4 or 5. You got a diagnosis already, so why do why do a calcitonin? So, but if you've got an MTC diagnosis on your FNA, and I think your pathologist, I saw those slides, and it was extremely well, reported slide. It was clear cut. It was but your clinical finding was not very suspicious for malignancy. It was just a solid cystic nodule, or it had components of cystic component within it. So it was not really a suspicious nodule. And I must say, most pathologists are not very comfortable in calling MTC, especially when the setting is not so, suspicious towards malignancy. And I must say, the pathologist did very well in making that call. But once you get an MTC diagnosis on FNA, please don't proceed for surgery without having your calcitonin, because that is your baseline. That is what is going to decide for you. Okay, post-surgery, 3 months, it dropped. And how much did it drop? That will then tell you, okay, this is going to be cured or not. Look at yours. Yours was 100 picograms. It went down to less than 2. I can confidently tell you that you've cured this patient. You don't need any additional treatment. The game is over for this patient. You've cured the patient.
So it means because there was some regarding screening, I was reading about there is role of screening calcitonin in all solitary thyroid nodules, and I think we all follow the same protocol. We don't do calcitonin except for that we have a high clinical suspicion. I think Senthil sir is also of the same opinion.
If you take my opinion, see, there are papers now. There are two schools of thought. One is any at-risk nodule, that is a risk of thyroid carcinoma in the family, okay, and then they present with a nodule, then a recurrent nodule, then a nodule which is very hard, a nodule in more than 40 years or 45 years of age. So you classify or term it into a group called at-risk group, and there you always screen a calcitonin, okay? And, because the FNAC may not be conclusive unless the cytopathologist is very experienced. And you see, in a corporate, the cytopathologists keep rotating. And even in a medical college, people get transferred, they get promoted. And sometimes, the mid-level people or the junior most will be in charge of the cytopathology. So there is no harm in screening. So this is the way we do. Then there are studies which say sonologically solid, scintigraphically cold. We don't do scintigraphy as a routine. But then when we subject certain cases for scintigraphy, if it is sonologically solid and scintigraphically cold, then we have to subject to calcitonin and CEA, okay, and then to FNS. So this is how we proceed.
Great, sir. Thank you. Thank you very much. And now this is a last call for all our participants. The forum is open for discussion. If they have any questions in their mind, they can come out with that, because now we are about to finish our time. And I think we are just well on time. And we had a very fruitful discussion. Chani, would you like to ask any question from our specialist? Yeah. So one last question, and after that, I would like you to please say a few words about our forum, Brandos. And then after that, I will request all our participants to open their camera so that we have a group photography, which will be like a memento for this meeting. So, sir, this last question: do you ask for IHC in all histopathologies, or in selective cases? And if it is selective, then in which particular subset of patient you ask for IHC. Like in our case, there was no amyloid in ISC. So do you think we should ask for ISC, and or we are very well done with it? It was a medullary thyroid cancer. Any specific other findings that you would like to see with ISC that we may not be knowing, sir?
Okay, I mean, I go with the pathologist. See,
Okay.
IHC only adds as an adjunct to your histopathology, right? So if you have a doubt in your histopathology, IHC will help you confirm which way you're going. But there are certain in MTC, just because it's amyloid positive, it's not going to change prognosis. It's only going to help you diagnosis. So if you've got a IHC which is going to help you prognosticate, then always do the IHC. But if your IHC is meant only for diagnosis, but if your histopathology was clear cut, then that immunohistochemistry may not be needed.
Fine.
That's how I.
So yeah. So if my histopathologist is confirmed that it was an MTC, so IHC is not required, and also my calcitonin was also confirmatory, right? Fine, sir. Because we asked the patient for ISC, so I think this is not required if that patient is also not willing. So we can very well omit this. Senthil sir, would you like to add?
Yes, sir. See, Dr. Deepak is quite right. It all depends on the pathologist. Sometimes the pathologists themselves will be less confident because, see, forget the amyloid. See, sometimes you are dealing with something which is not a differentiated one. So you want to rule out the other things, other conditions. So this is one indication where you have to do IHC when you are in a tier 2 city or you are in a less resource center. But when we are in a tertiary care center or in a corporate hospital, we always do IHC because the patient themselves will be reading up. They will be Google searching, they will be Googling, they will be well aware of their MTC, and this IHC will be, as rightly said, will prognosticate, and also, if at all the patient comes with a recurrence, will help us that we have not missed the IHC. See, the patient will not know that the IHC is not going to throw much weight, okay, in terms of surgical management. But then they might question you, they might sue you. You might be pulled up into a consumer court. Okay. So for at least these adversities, we have to complete the protocol, the treatment protocol. See, no harm in spending another 16,000 rupees for an IHC. The IHC will help us prognosticate, and you also will be a better surgeon, because what if they go to another surgeon and then they do IHC? Then it means you have missed out something. So these are points which may not help you in the treatment, but this is not for managing the medullary thyroid carcinoma. This is for managing the patient. Some patients will be troublesome when it recurs. Okay, madam. So I usually do IHC routinely, even in the medical college and even in the corporate Apollo hospital.
So thank you very much, and we really had a very fruitful discussion tonight. And for this, I am thankful from the core of my heart, and from the side of the team Brandos. I would like to thank all my guest faculties. So one last question, request, in fact, Deepak sir and Senthil sir, and if they can say something about how did they like this forum, a bit of it. It is a very small initiative from our part. We are running this activity for more than 2 years successfully, and involving more than 500 doctors from across the country. Through different means, we try to interact with each other and just try to create more awareness about breast and endocrine surgery. A few words will infuse confidence into my team. Thank you very much, sir. Yeah.
Okay. Thank you, Sudhi. I mean, I must congratulate you for an initiative like this. Remember, we are all people on a journey in life, and you want to succeed in this journey in life, it is actually one of lifelong learning. And finishing degrees don't matter. It's actually what keeps you on your toes and sharpens your knowledge is what is the most important. Yeah, and forum like this help you sharpen that and get better, and insights, because what you may read will not translate to something like this, because you get an experience from a person who's actually gone before you in this journey. And I look at life as a journey. And if in this journey, if you don't pepper yourself with learning, you fail. And this is one such aura where you learn, right? One suggestion I could have for you is, you had a case which is you had a full spectrum of the case. But if you actually peppered that as a symposium where you stopped at each point, where you did the scan, where you did the FNA, then you ask the faculty to put in or give your inputs, then you don't have a continuous presentation, but you have inputs at every, let's say, 3-4 slides, which then make the learning more, what do I say, real time. That means at that point, I mean, I would have questioned you, what was the ultrasound, what is the size of the scan, of the nodule? What was the, I didn't see that in the histopathology. What was the size of the nodule? Why did you do a lateral lymph node dissection? Those are challenging questions to you, which actually helps learn. And level 2, 3, 4, 5 dissection, even though it's easy to do, but why was it done? You look back histopathology, you look back retrospectively, there was no need for it. But did you need a bilateral central neck dissection? Absolutely, right? So those are that's one way to intersperse the case with questions at periodic intervals, which then bring in the learning at that point, rather than try to get all the learning at the end.
Sure, sir. So we are always open for learning, and your suggestion is one of the part we take it as a learning point, and certainly in our upcoming forums, we would certainly try to inculcate these points. Thank you very much, sir. Sir Senthil, sir, would you like to say something about our forum?
Yes, madam. I would like to congratulate you. It is very nice that you have become a super specialist and you have organized a beautiful conference in Meerut. I was really impressed. And now you are doing a payback to society, interacting with the doctors and imparting them why you should do a CCLND, how to diagnose medullary thyroid cancer, who will be the right person, why should somebody refer to an endocrine surgeon, because see, everybody thinks cancer oncologist. It's not so, because see here, there is no role for a medical oncologist, there's no role for radiotherapy, all limited. So how we differ as an endocrine surgeon from an oncologist, why we are a super specialist, why are we a specialist group as endocrine surgeons. So to propagate that idea, to update, to dissipate the acquired knowledge for the good of the doctors and for the benefit of the society, you are doing a good job. I wish you continue from 2 years to 20 years. So wish you all the best. It's a wonderful forum. I enjoy being here. It's my privilege. Wish you all the best.
Thank you very much. So may I request all our participants, if they can momentarily open their cameras, so we can have a selfie together. And after that, we'll conclude our session. Yeah, thank you. Thank you very much, Dr. Dinesh, Vijay sir, Dr. Nityasha, Dr. Pankaj, Dr. Mushtaq, Dr. Sharmeen. Okay, fine. So this is how, yeah. Thank you very much, Dr. Devin sir. And before we conclude, there is a couple of announcements. So our upcoming BRENDOS meet will be in December. December is an even month. So that time we have a breast meeting planned, and we have very interesting topics. And this will be the last session of this year. So we will try to make it more interesting. And we will try to involve radiologists so that we can learn about MR mammographies. So those who deal with breast tumors, I request them to please join us join us in our December meet. The details I will be sharing soon. Another important point, all our meetings are recorded and are uploaded on YouTube for future references. So if you happen to miss our meeting or any part of our meeting, please don't worry. Everything will be uploaded online. And as you have seen, we remain very basic just to upskill our clinical knowledge. So you can very well go through these presentations later on also. The details I will be sharing soon. So with this, I once again thank all my guest faculties, my co-speaker Shani, and all those participants who remained with us throughout, and they took out their precious time to join us. Thank you once again for being part of this program. I now request we can now conclude the meeting. We can now very well log out of this meeting with the promise that in subsequent meetings we'll meet again. Thank you very much.
Thank you very much, madam.
Thank you. Thank you, sir.
Thank you, Deepak.
Thank you, sir.